And we will be beginning with FLT3 positive acute myeloid of Andrew and AML know him well. But just to complete the formalities, he's adjunct associate professor, hematologist, and medical research future fund fellow at Alfred Hospital, Melbourne, Australia, where he conducts clinical and translational AML research in collaboration with Monash University, Melbourne. He joined the Alfred Hospital way back in 2008, where he has led the AML program as principal investigator. He has authored over 100 publications in peer-reviewed journals. He has been the AML Working Party chairperson for the Australasian Leukemia and Lymphoma Group since 2009. I'm thankful to Novartis for supporting today's webinar, and I'm thankful to Mice Ideas for conducting this for us. As usual, in the question box, and I'm sure that all of you are going to type your questions, which we'll be discussing in the later part of this webinar. Questions will be the key because that will be the way to solve your problems that you face in day-to-day practice or even the academic question. Group, and thank you for logging in. Understand that 900 plus of you have registered, over 50 from outside India. All of you are welcome. And now I hand over to Dr. Abu.
I thank and areas educate you disclosures. Threefold. Firstly, to obviously get patients into remission, which is important to prevent patients from suffering the consequences of bone marrow hypofunction. The second objective is to eliminate residual disease.
It's different.
You mean as a subset of low-dose RC?
That's it.
Yeah. So it is. So I'll just explain how the study. And currently our major pillars of therapy in this area include consolidation chemotherapy and obviously allogeneic stem cell transplant. The third key objective for some patients that either fail initial therapy or have relapsed disease is to treat relapse and refractory AML. We know from several decades of genomic interrogation that the genomic complexity of AML is substantial, not only at diagnosis, but also in remission with respect to minimal residual disease and clonal hematopoiesis, which can act as a reservoir for future relapse. And we also know that at the time of relapse and with every subsequent treatment failure, that the epigenomic and the genomic complexity increases, which makes the job of targeted and effective therapy very difficult. Shown here are some of the randomized studies which have led to FDA approval of these drugs in the US and also in other parts of the world at various stages. You can see here midostaurin, the FLT3 inhibitor, CPX351, the liposomal encapsulation of Araci and daunorubicin, the hedgehog inhibitor glasdegib, the IDH2 inhibitor enasidenib, and so forth. So there has been substantial progress in AML in the last 3 years with many new therapies. And the question is, what is the impact of some of these therapies on our practice and how can we use them most effectively? So I come back now to the objectives of new therapies, and you can see that we have a number of these new therapies which have utility in remission induction and also for patients with resistant and refractory disease. You can see that the clinical landscape in AML has now changed quite radically. In the past, for patients who were fit for intensive chemotherapy, we basically utilised 7+3. For patients who are unfit for intensive chemotherapy, we generally had low-dose Araci or hypomethylating agents. And for patients with relapse and refractory disease, it was some form of combination salvage chemotherapy. You can see now the landscape is quite different. So for patients with core binding factor, For those who have availability of the drug, gemtuzumab ozogamycin is shown to be quite useful. For patients with FLT3 mutant AML, midostaurin was the first of the agents which was approved in 2017. In the elderly AML area, you will be aware of the success of venetoclax in combination with azacitidine in the VRLE-A study, and I will discuss this briefly. And furthermore, in the relapse and refractory setting, again, there are a number of targeted therapies, again, H2, IDH1, and FLT3. Let me start with some words about midostaurin in combination with intensive chemotherapy for FLT3 mutant AML. FLT3 mutant AML makes up approximately 20% of patients with AML, and you can get the road to registration for midostaurin, or its trade name Rydapt, was a long journey commencing in 1986 when PKC412 was first synthesized. The first in-human study was done in 1994, and the mutation affecting FLT3-ITD was identified by a Japanese group in 1996, and the TKD mutation in 2001, again by Japanese investigators. The first clinical study in AML was done by Richard Stone in 2003. There was only modest activity found for midostaurin as a single agent, and its utility in AML came from screens which identified that PKC412, which was originally designed to target PKC, also targeted FLT3, c-KIT, and VEGFR2. The phase 1b study conducted by Richard Stone combined midostaurin with daunorubicin and Ara-C, and it was found to be well tolerated. And so this schedule was taken into the ratified trial. The results were presented in 2015, and obviously it was a positive study which led to FDA approval on the 28th of April 2017. The study was a randomized trial, 1-to-1, one of the largest global studies ever conducted in FLT3 mutant AML. You can see many cooperative groups participated in the study. The backbone of the therapy was daunorubicin at 60 milligrams per metre squared per day for 3 days, in combination with Ara-C, and also high-dose Ara-C consolidation. And the midostaurin was combined through induction, consolidation, and also 12 months of maintenance. And it was a placebo-controlled study with a primary endpoint of overall survival. Patients were enrolled if they had a FLT3 mutation with an elevation ratio of at least 0.05. Most of you would be aware of the positive primary outcome, which was a 22% reduction in the risk of death, with a hazard ratio, therefore, of 0.78, with a highly statistically significant p-value. So what's happened with respect to moving the results of RATIFY into clinical practice? You can see from the clinical trial that of the 717 patients that were enrolled to the induction phase of the study, only 66% of patients made it through to consolidation, and only 1/3 of patients into the maintenance phase. So, as I mentioned before, patients needed to have a FLT3-ITD elevation ratio of at least 0.05. And there are many questions include, what about patients with ITD ratios below 0.05? Should those patients should receive midostaurin or not? Furthermore, is there a benefit for patients with FLT3 TKD? And obviously the answer is yes, and I'll show you data to that effect. The study was done with daunorubicin at the backbone in combination with Ara-C. You can see that the complete remission rate was 59% with midostaurin compared to 54% with placebo. But what about daunorubicin? Is this a drug which can also be substituted in place of daunorubicin? Many of you would be aware that there are studies which have done this, but obviously none of these are randomized in the nature that RATIFY was. What about azoles? Can they be used in combination with midostaurin during induction? Yes, they can. However, you should be aware that combination with azoles increases the effective dose of midostaurin by almost 50%. And so one needs to be aware of the possibility of increased toxicity. When should you start azoles? generally my recommendation is to start them on day 4 after the anthracycline phase if you're going to utilise these antifungal drugs as prophylaxis. With respect to people that don't get into remission on the first induction cycle, this occurred in 23% of patients on the RATIFY trial who received a reinduction. And in the RATIFY trial, they utilised the same induction regimen for the second induction, so 7+3 with daunorubicin in combination with midostaurin. In RATIFY, this was done on day 21 for patients that had more than 10% blasts in the bone marrow. Nowadays, with the availability of gilteritinib, it does beg the question, how do we manage patients with resistant disease? Should we do reinduction with midostaurin, or should we move to a second-line FLT3 inhibitor such as gilteritinib? With respect to consolidation therapy, the conventional 3 grams per metre squared twice a day on day 1, 3 and 5 was used in RATIFY. But the other question is, what dose of RSC should you use in older patients? And the general recommendation is to reduce the dose of RSC to 1 gram per metre squared in older people. However, as you know, patients in the RATIFY trial only went up to the age of 59. But there is German data showing that combination with conventional drugs in older patients up to the age of 70 is feasible. However, you should be aware that the early treatment-related mortality is higher than in young people, and there appears to be a higher signal with respect to cardiovascular complications, but this potentially is manageable. With respect to consolidation therapy, we know that the RATIFY trial commenced midostaurin on days 8 to 21, but obviously the practical question is, could it be started on day 6 after completion of high-dose RSC? With respect to midostaurin in maintenance therapy, another question which commonly arises is, if the patient is destined to have an allograft, should you use maintenance midostaurin prior to the allograft? And in our country, we generally do that because of the potential that maintenance midostaurin might halt the disease and produce a more favourable outcome after allograft if it was able to control disease effectively. And the last question is, in the RATIFY trial, about 6% of patients were taken to transplant. And the question is, what about the use of post-allograft FLT3 inhibitors? So just trying to address some of these questions with data. The first one is the question of patients with NPM1 mutant AML with FLT3 ITD, but with a low allelic ratio. And this is trying to address the question of whether people with a very low allelic ratio of FLT3 should also receive the drug or not. Interestingly, you can see here that the effect on this group was actually more substantial than even other subgroups of FLT3 ITD AML with high ratio disease. And so therefore, I don't think there's any problem with commencing midostaurin for patients with FLT3 allelic ratios even below 0.05, because there's no evidence that there is a dose-response relationship with the level of FLT3 ITD. The second issue is, what about patients with FLT3 TKD? And again, you can see here there was a substantial improvement in survival with midostaurin compared to placebo amongst patients with FLT3 TKD. So the evidence is quite robust that patients with not just ITD but TKD should receive midostaurin as first-line therapy. Most of you are aware of the European Leukemia Net stratification of risk into those with mutant NPM1 with a low FLT3 allelic ratio and then other subgroups. And Constance Donor from Munich has done an analysis of the RATIFY trial, where you can see here these are the 3 risk groups of FLT3 ITD at either low allelic ratio with NPM1 mutation, high allelic ratio with NPM1 mutation, low allelic ratio with wild type, etc., dividing the patients treated in RATIFY into favourable, intermediate or adverse risk. Just note that patients with FLT3 low allelic ratio with an NPM1 wild type are considered adverse if they also have concurrent RUNX1, ASXL1 or P53 mutations. However, this represents a relatively small subgroup. You can see here that these are the risk outcomes for these 3 different groups. But what about the impact of midostaurin on these three groups and also the role of allogeneic stem cell transplant? So this is illustrated here in this figure, which shows the three risk groups: favourable, intermediate and adverse. You can see in red the benefit conferred by midostaurin in each of these groups compared to placebo. And so the conclusion here is that midostaurin is beneficial regardless of the risk group of FLT3. Second, the role of allograft. You can see that the role of allograft and the benefit is highest in the adverse risk group and progressively lower amongst intermediate and favourable risk patients. And so the question is, should you allograft patients with favourable risk AML who generally have a low FLT3 allelic ratio and concurrent NPM1 mutation? What we generally do is we measure NPM1 MRD in these patients, and if these patients are MRD negative, then we generally consider not allografting these patients because of the reduced benefit ratio of allogeneic stem cell transplant. What about post-stem cell transplant treatment? Well, there's not a randomised trial so far that is large enough with midostaurin to firmly recommend the use of midostaurin in the post-allograft setting. However, there is a small study which shows the benefit of sorafenib in terms of relapse-free and overall survival, as you can see here. It should be noted, however, that this was not a very large study and it took a long time to accrue. You can see there was only 83 patients here, and the study was actually closed because of slow accrual. However, despite that, you can see that there is a substantial benefit with sorafenib, and obviously we very much are interested to see the results of the Cancer Institute trial conducted by the BMT group, looking at more modern FLT3 inhibitor in terms of gilteritinib, also in the post-allogeneic stem cell transplant setting. So the next area that I wanted to discuss is the other FLT3 inhibitor, gilteritinib, which was initially approved for patients with relapsed and refractory FLT3 mutant AML. As many of you will know, gilteritinib, like midostaurin, is a type 1 FLT3 inhibitor which targets FLT3 TKD as well as ITD, in contrast to type 2 inhibitors such as sorafenib and quizartinib, which only target FLT3 ITD, and patients with FLT3 TKD are resistant to these drugs. So there were two parallel randomised studies done in the relapsed and refractory state with two different FLT3 inhibitors. One was gilteritinib and the other one was quizartinib. The gilteritinib study was called the Admiral study, and the quizartinib study was called Quantum R for relapsed. You can see that both studies were conducted along very similar lines. So the gilteritinib, in this case, was a 2-to-1 randomisation versus either low-dose Ara-C, azacitidine, combination chemotherapy called MEC, flag-idarubicin, and identical drugs used in the Quantum study, except that they did not use azacitidine. You can see that both studies were positive in terms of their primary endpoint of overall survival, and that for gilteritinib, the hazard ratio for survival improvement was 0.67, which translated to an improvement in survival from 5.6 to 9.3 months, again with a highly statistically significant p-value. Many of you are aware that quizartinib was not approved in the US, however it is approved in Japan, whereas gilteritinib is approved in several jurisdictions, including the US. This table illustrates some of the similarities and differences between the Admiral and Quantum R studies. We can see that with gilteritinib, the most impressive aspect of this drug is a response rate of 54% in people that have failed predominantly intensive therapy. You can see that the true CR rate was 21%, and that when you compare gilteritinib with intensive chemotherapy, those that were selected by the investigators to receive intensive chemotherapy as the treatment of choice, that the gilteritinib was still able to produce a better response rate. We've used gilteritinib for a number of years now, and I can tell you that it's such a good thing to be able to use an oral inhibitor of FLT3 compared to MEC or flavarotobacin, where the patient has to spend many weeks in hospital to get through that suboptimal therapy. To be able to put the patient onto an oral drug and potentially send them home with very relatively few side effects, I think has been a transformative feature for patients with this problem. With respect to the two inhibitors, you can see that the median time to remission with gilteritinib is almost 2 months. So we need to be a little bit patient in the initial stages. Some patients go into a very rapid remission after 1 month, but we certainly need to give 2 or 3 cycles to sometimes see the full benefit of this therapy. Quizartinib does work a little bit faster, but it does have other problems such as QT interval prolongation and also lack of availability beyond Japan. The median duration of remission with gilteritinib is almost 1 year compared to 2 months for conventional chemotherapy. And I think this is a really important point, that the remissions achieved with gilteritinib are not forever, but certainly enough to take patients to transplant if that is possible. Early mortality is very low, and you can see even when randomised to those that got intensive chemotherapy, the gilteritinib medication was superior numerically. In terms of bridging to transplant, you can see that a quarter of patients on the gilteritinib arm got blood graft. So even though it's a tablet, its ability to get people to transplant was higher than chemotherapy. Furthermore, on the study, the AML study, patients were allowed to have gilteritinib after transplant. It was allowed to be commenced 30 days after transplant, and you can see that those that did receive it had a superior survival compared to those that did not. However, if patients are treated with gilteritinib, there is the possibility of relapse, and resistance mechanisms involved include activation of the RAS and MAPK pathway. So these need to be considered in patients that fail therapy. In terms of adverse events, the one adverse event I'd like to point out is ALT increase, because if you use this drug, particularly in a post-Philip setting, then it's important to be aware of the possibility of gilteritinib-associated liver dysfunction, because this could be confused with graft versus host disease in the post-transplant setting. And so a liver biopsy is sometimes required to distinguish between these two possibilities. Another feature of the AML study with the use of gilteritinib for relapsed and refractory patients was this very difficult subgroup of patients which we call triple mutant AML. These are patients that have FLT3 mutation in combination with DNMT3A and NPM1 mutations. For reasons we don't fully understand, this group does particularly well with gilteritinib, whereas with conventional chemotherapy, and even sometimes with allogeneic stem cell transplant, this is often a very difficult group to treat with long-term effect. And so for patients that relapse that have this triple mutant phenotype, then gilteritinib is certainly the drug of choice. The next area I'd like to talk about is venetoclax. Many of you would be aware that at the recent European Hematology Association meeting, venetoclax was presented as part of 2 pivotal phase 3 studies, one in combination with azacitidine in patients aged 75 years or older or considered unfit for intensive chemotherapy, and also in combination with low-dose Ara-C in the similar patient subgroup. And so this is a really important advance, because many of you will know that the majority of patients diagnosed with AML are over the age of 60, and you can see that several decades of chemotherapy research and trials has not really led to substantial improvements in long-term survival for this population of patients. The evolution of BCL targeting into therapy for AML has been a long journey which spans over 20 years, from the original cloning of human BCL2 from the 1418 follicular lymphoma translocation by Sugimoto and Cleary way back in 1986. David Bowe from the Walter Eliza Hall Institute in Melbourne discovered the pro-survival function of BCL2, and this was in fact the first oncogene discovered to have pro-survival rather than proliferative activity. Pivotal to the development of inhibitors of pro-survival proteins was the crystallization of the BCLX structure in 1996, which showed that BH3 proteins bind to this hydrophobic groove on the surface of pro-survival molecules. So the medicinal chemistry development of small molecules which could mimic BH3-only proteins led to the development of ABT737, the dual BCL2-BCLX inhibitor, and then the selective BCL2 inhibitor published in 2013. The phase 1 study of venetoclax in AML demonstrated only modest activity with a 19% response rate and a duration of response which was very short. And so it wasn't until venetoclax was combined with conventional therapy for older patients with AML, hypomethylating agents, and low-dose RSC that the benefit of BCL2 inhibition was realised, with very promising response rates observed in these early phase studies. This led to accelerated approval by the FDA in 2018 and 2 confirmatory pivotal studies called VIALE-C for venetoclax in combination with low-dose RSC and VIALE-A for venetoclax in combination with cytidine. The VIALE-A study, this was done, as I mentioned before, in patients aged 75 years or older, or if for younger patients they needed to have one of these comorbidity factors, which include impairment of the heart, angina, lung impairment, or poor performance status 2 or 3. You can see here a randomization on a 2-to-1 ratio to venetoclax plus azacitidine versus placebo plus azacitidine. And the primary endpoint was overall survival, and the co-primary endpoint was response rate. You can see that the response rate was very impressive in this older AML population, with a response rate of 66%, with about 37% of patients achieving true CR. And this contrasts in the placebo group, where the response rate was typical of hypomethylating agents on their own, about 28%. The other impressive feature of venetoclax plus azacitidine is that it achieves remission very rapidly. So you can see median time to CR or CRI of only 1.3 months. This is really important because azacitidine alone often requires 3 or 4 cycles to achieve response. And achieving response more quickly than this, I think, gets patients into remission, improves their quality of life, and also prevents such patients from succumbing to fatal infections. And as you can see, almost 50% of patients achieved remission before the commencement of cycle 2. So the primary endpoint was met in VIALE-A. You can see that there was a survival improvement from 9.6 months median to 14.7 months for those receiving venetoclax. And this was associated with a 34% reduction in the risk of death. Most impressively, I think, is the fact that although with 20 months median follow-up so far, there looks to be a proportion of patients who are still alive at 2 years, which is just under 40%, which I think for an elderly, unfit population is a very, very good result. You can see that the subgroup analysis shows that there was improvements in favour of venetoclax across the different AML subgroups. Most impressive, I think, is the survival benefits, which appear to be the case for patients with IDH1 and IDH2 mutant AML. You can see that the hazard ratio for these subgroups is 0.28 and 0.34 respectively, which I think is an extraordinary result. However, you can see that there are still some more difficult subgroups, such as P53 mutant AML, and I will talk about this shortly. The parallel study was called VIALE-C, and this was also presented at EHA and also at ASCO this year. The major difference between VIALE-C and VIALE-A is that this study included patients who had prior exposure to hypomethylating agents. So 29% of patients most likely failed azacitidine or decitabine for the treatment of MDS. Similar to VRA, this was a 2-to-1 randomized double-blind placebo-controlled trial. And the schedule of venetoclax was slightly different to VRA, with 600 milligrams of venetoclax being used after a dose ramp-up compared to 400 milligrams in VRA. So you can see here the secondary endpoints were all in favour of venetoclax. And so complete remissions were 28% versus only 7% for low-dose ROC in combination with placebo. Interestingly, the duration of remission was 17 months in the RLC, which was actually identical to the duration of remission for those achieving CR in the VRA study with azacitidine. You can see that the combined CRI rate with venetoclax plus low-dose ROC was 48% compared to only 13% for placebo. Transfusion independence was significantly higher for low-dose ROC plus venetoclax, as was median event-free survival. In terms of overall survival, you can see that with venetoclax, overall survival was 8.4 months median compared to 4.1 months for low-dose ROC plus placebo alone. And again, this was associated with a 30% reduction in the risk of death with a hazard ratio of 0.7 and a p-value of 0.04. In terms of the subgroup analysis overall survival, the main one which I thought was particularly interesting was this subgroup of patients with NPM1 AML. And as I'll show you, it seems to be that patients with NPM1 AML have a very interesting sensitivity to venetoclax, which may explain the very results seen in this subgroup of patients. This is a graph which illustrates the different subgroups, and I'll go through this slowly. So this is the results from the VRC study, and over here, VRA. You can see that the composite response rates for those in the venetoclax arm, 48% with VRC and 66% for VRA with azacitidine. You can see here the complete remission rate for both studies, and as I mentioned before, the duration of CR was almost identical for both studies. With respect to the various subgroups, if you look at the patients that did not have prior exposure to hypomethylating agents in the VRC study, you can see that the response rate was 53% compared to 66% for patients getting venetoclax plus azacitidine. In the NPM1 subgroup, in fact, low-dose ROC produced a higher numerical response rate of 79% compared to azacitidine plus venetoclax, which had a response rate of 67%. However, for patients with IDH, FLT3, and P53 mutant AML, you can see that azacitidine in combination with venetoclax produced higher response rates than either low-dose ROC plus venetoclax or the placebo arm in both studies. So 75% response rate for patients with IDH mutant AML and similar values for FLT3 mutant AML and slightly lower response rates for patients with P53 mutant AML. I'll come back now to this NPM1 mutant subgroup. So you can see here, this is analysis of patients from the phase 1-2 studies who received either hypomethylating agents or low-dose ROC in combination with venetoclax. So you can see here the age range of this population was 65 to 87 years of age. And you can see, although there were only 27 patients with NPM1 mutant AML, you can see that at 2 years, the survival rate appears to be over 70%, which I think is quite extraordinary. If you compare this with a population of patients treated with hypomethylating agents between the ages of 55 and 85, again with NPM1 mutant AML, you can see that there doesn't appear to be such a good survival outcome and no difference to patients who are not NPM1 positive. And so I think this illustrates that perhaps venetoclax is doing something specific for this subgroup of patients. And so a conclusion might be that venetoclax-based therapy might be a new standard of care, particularly for older patients with NPM1 mutant AML. And I'd just like to share with you one case which I think is quite illustrative and which has been recently published as a series of patients in the British Journal of Haematology. So This is a patient who has NPM1 mutant AML. You can see this patient received intensive chemotherapy. This is RT-qPCR, so MRD analysis for NPM1 mutation. You can see that the coloured squares represents positive detection in the bone marrow. This was at diagnosis and post-induction. The patient received consolidation therapy, and you can see the patient became MRD negative. The open squares represents the limit of detection using ABL amplification. You can see that after a few months, the patient became MRD positive, and with further monitoring, the patient had a log increase, which fulfills the ELN definition of MRD progression, and it was confirmed on the second bone marrow. And so in this situation, we would often be faced with the possibility of either taking the patient to allograft with rising MRD, which we know is associated with a poor outcome, or giving the patient conventional chemotherapy prior to allogeneic stem cell transplant. We used venetoclax in combination with low-dose Ara-C. We only gave 14 days of venetoclax, and fascinatingly, this patient had a full log reduction with one cycle of therapy and became MRD negative after 2 cycles of therapy. Because the patient was in morphologic remission still, the patient required no transfusions, no dose ramp-up, was completely managed as an outpatient. The regimen was minimally toxic with no grade 4 neutropenia or thrombocytopenia, and in MRD remission, the patient was then safely taken to allogeneic stem cell transplant, remains well to this day. And so I think for patients with NPM1 MRD failure, certainly you should consider this type of approach rather than intensive chemotherapy. So now looking at the possible reasons for treatment failure after venetoclax-based therapy, this is a paper that was recently published in collaboration with MD Anderson. It combined all of the patients that we had treated in the phase 1-2 studies with venetoclax hypomethylating agents, all low-dose Ara-C, and divided the patients into patients that had a durable remission, which we defined as being 12 months or more, patients that achieved an initial remission but relapsed, which was group B, patients that were primary resistant to the therapy, group C, and those here are called uncategorized. This is where patients achieved a remission, but the remission was less than 12 months. So we identified 2 major findings. First of all, for patients that received venetoclax in combination with low-dose chemotherapy amongst these older patients, that there were 2 major genetic causes of relapse. The first was P53 mutation, and you can see here these were all cases that we had parallel samples of diagnosis and also at relapse. There were 2 interesting findings here. First, there were patients that did not have P53 mutation detected at diagnosis that developed P53 mutations at relapse. And the second interesting observation is that every single case that we assessed had a biallelic abnormality at relapse. And so the hypothesis here is that if the patient has a heterozygous or absent P53 mutation status at diagnosis, then remission is achievable. However, the adaptive resistance caused by either 2 P53 mutations present in the same patient or a P53 mutation in combination with loss of the 17p locus can result in resistance to therapy. The second mechanism that we identified was FLT3 ITD. And you can see in orange, this represents mutations which expand even though they were detected at diagnosis. And red illustrates mutations that were not detected at diagnosis with the sensitivity of the assays used, but were detected at relapse. And so these were emergent mutations. Shown here are 2 single-cell sequencing analyses illustrating the emergence in blue of the FLT3 ITD clone, even though it was in combination with IDH and NPM1 mutant AML. You can see that these mutations, if they did not contain the FLT3 ITD clone, were extinguished at remission and didn't appear at relapse. However, FLT3 ITD was the driver of progression in this case. And in this second case, again, you can see that FLT3 ITD was not detected at diagnosis, that emerged at the time of relapse. And interestingly, in this patient, there was a polyclonal relapse mechanism with many mechanisms of progression, not just FLT3 ITD by itself, but also FLT3 TKD and two different RAS mutations, and also a different FLT3 point mutation. So this patient is illustrating parallel mechanisms of resistance by activating either the FLT3 or the RAS pathway in a patient that received venetoclax. The last area that I'll talk about briefly is maintenance therapy. We haven't used maintenance therapy as a routine standard of care in AML because there has not to date been a study which has demonstrated improvements in overall survival. Why do we need maintenance therapy? Well, particularly in older patients with AML, you can see that the relapse risk is substantial, and so the majority of patients over the age of 60, even if they achieve a remission that at 2 years, almost 2/3 or more of patients have already relapsed. Furthermore, we know that if we use MRD, that patients that have flow cytometric MRD levels of greater than 0.1% have a very high chance of relapse. And so there's many reasons why further treatment beyond consolidation therapy is relevant. Excuse me. So what are the objectives of maintenance therapy? First of all, we would like if it's convenient. Second, minimally toxic. And third, effective, obviously, by either targeting diverse clones, suppressing MRD, hopefully prolonging remission, and the ultimate is to improve survival. This is important because we know that there are many diverse clones in AML, and so just one targeted therapy may not be sufficient to suppress MRD. And so this led to the conduct of the QUASAR study, which is a randomized study utilising an oral hypomethylating agent called CC486. The study was placebo-controlled and enrolled patients aged 55 years or older. Patients have received induction plus or minus consolidation therapy. Core binding factor AML was excluded, and patients needed to have complete remission or CR with incomplete hematologic recovery. Patients were not considered to be candidates for allogeneic transplant by physicians at screening, and there had to be adequate count recovery after chemotherapy to be enrolled onto the study. Patients received 14 days of CC486 at a dose of 300 milligrams per day, and if patients had bone marrow assessments every 3 months and were found to have a slight excess of blast indicating early relapse, they could receive a 21-day extended schedule of CC486. However, if patients had more than 15% blast detected, then they were considered to have relapse disease and were taken off study. The primary endpoint for the QUASAR study was overall survival. You can see here that the interesting factors about baseline characteristics was that the proportion of patients that did not receive any consolidation therapy was 22% in the CC486 arm and 18% in the placebo arm. You might ask, why would some patients not receive consolidation therapy? Well, I think it's observed that particularly in these older patients, some patients who receive induction really have quite complicated courses of therapy, and in some cases it's difficult to give consolidation therapy because the patients either had very severe sepsis and is too weak to have consolidation therapy, or the patient has had very delayed count recovery, which makes giving consolidation therapy hazardous. And so in this situation, I think it's positive that this study included such patients because they certainly do occur in real-life situations. Another interesting aspect of the QUASAR study was that at the time of enrolment, almost half the patients had MRD detected using centralised flow cytometry with 0.1% MRD as the threshold for positivity. And you can see that the primary endpoint of overall survival was very much in favour of CC486, with an almost 10 months median prolongation of survival, with a 31% reduction in the risk of death. And patients in the CC486 arm at 2 years, about 50% of patients were alive, translating into a median 45 months. With respect to the subgroup analyses, it was interesting that patients with CRI, who are known to not have as good a survival outcome as patients in CR, also benefited from CC486. Also, patients with poor cytogenetic risk, which was certainly a surprise for all of us. And also, as I mentioned before, patients that didn't receive consolidation therapy, these patients potentially had the biggest benefit of maintenance therapy with CC486. And lastly, the patients that had positive MRD, you would think that this patient group wouldn't do so well with CC486 maintenance, whereas in fact the opposite was the case, and this group had a particular benefit from maintenance therapy. And so with CC486 being positive, we would expect that at some point this could be seen favourably by the FDA and become another treatment possibility amongst our new therapies for AML, and filling the gap between induction therapy and also salvage therapy as a new standard of care for maintenance treatment in AML. So these are my concluding comments. Obviously, there's many new drugs. I think it's fair to say that venetoclax plus azacitidine, because of the results of the VRE-A randomised study, would suggest that venetoclax is a new standard of care for older and unfit patients with AML. I think for patients with relapsed and refractory disease, targeted therapies seem to be preferred over conventional chemotherapy. I've talked about gilteritinib. I haven't talked about IDH inhibitors, but I think there will be a similar conclusion there. And because of this fact, I think it's extremely important that repeat molecular testing is done at every progression, because potentially targeted therapies could be utilised for patients with IDH1, 2 or FLT3 mutant AML, and that these mutations can be present even when they're absent at diagnosis. And so monitoring patients again at treatment progression is important to identify these alternatives to intensive chemotherapy. And with respect to clinical practice tips, I would refer you to this article which I co-wrote with Courtney Donato, which will discuss some of the intricacies of management for patients receiving either venetoclax, IDH inhibitors, or gilteritinib. So with that, I'll stop there, and thank you for your attention, and obviously very happy to take any questions. Thank you.
Thank you so much, Dr. Andrew. That was fantastic. And we do have some questions for you. One question is about venetoclax. Is the dose of venetoclax different when the accompanying drug is different?
You mean azacitidine or low-dose ARC?
That's it.
Yeah. So it is. So I'll just explain how the studies were done. So in the hypomethylating agent study, this was taken from 400 milligrams initially, and then to 800 milligrams, and we even went to 1200 milligrams with venetoclax. What we found was that even with the 800 milligram dose, patients had very long time to count recovery, and so most of the patients eventually had to go back to 400 milligrams, and so therefore venetoclax 400 milligrams was the recommended go-forward dose in combination with azacitidine. In the low-dose ARC study, it was a completely separate parallel study, and the starting dose there was 600 milligrams. And again, this was also examined at 800 milligrams, but a similar problem to VRE-A was found with delayed count recovery, and so 600 milligrams was set as the conventional dose. Whether we need 600 milligrams with low-dose ARC or whether we could use a flat dose of 400 across the board is possible, but we don't currently have the data to support that.
Thank you. Also a question related to the type of HMA which you'd like to link with venetoclax.
Yes, so the phase 1b/2 studies combined venetoclax with both azacitidine and decitabine, and in fact the outcomes were very similar in terms of response rate, median survival, toxicity, and other parameters of response such as MRD. And so I don't think there's any problem with using decitabine. The reason for using azacitidine was that it was felt that it was a more widely used hypomethylating agent across the world, rather than decitabine.
Another question related to venetoclax is, when the counts are very low, you stop venetoclax or push it up with GCSF?
Yeah, so this is a very important and complex question, and I certainly refer you to the blood paper because we went into great detail to try and explain how to use venetoclax safely. So what we generally do is we start with venetoclax plus either hypomethylating agent or low-dose RSC, and then if we days 21 to 28, if the patient is potentially responding, that is, there's no peripheral blood blasts, and you're not sure if the patient's in remission or not, we would strongly urge that a bone marrow assessment is done. We generally don't use GCSF during the first cycle, and then when we do the bone marrow assessment, if the blast count is below 5%, then the disease has obviously been potentially cleared, and then we will stop venetoclax at that point and then start GCSF. The most interesting aspect is that we sometimes see patients go from a neutrophil count of 0 to normal, and normal being like 2 or 3 times 10 to the 9 per litre within 4 or 5 days. So this is a really important point. If you do not stop the venetoclax, the neutrophils may not come back. And so stop the venetoclax, give the GCSF, and when the neutrophils have recovered along with the platelets, then start the next cycle. With the next cycle, we would again usually suggest not to use GCSF. However, if you note that the neutropenia is perhaps more than 7 days in terms of count recovery, in terms of beyond day 28 count recovery delayed by more than 7 days to a neutrophil count of 0.5, then on the next dose, we'll consider using GCSF and drop the venetoclax exposure from 28 to 21 days. So it's a little bit complicated to explain all of this, but please refer to the article which goes into this in more detail.
The question is related to about posaconazole plus venetoclax. This question must be because posaconazole in India is very cheap. Venetoclax is pretty expensive. And they want to know whether they can reduce the dose of venetoclax by joining it with posaconazole, and what will be the dose structure.
Yes, so again, this is a slightly complicated question. In Australia, we have the same health economic pressures, and currently venetoclax is approved, but not reimbursed. And so we also try to reduce the cost of venetoclax by combining with posaconazole. And so what we do is we do the dose ramp up first without posaconazole because that would make things complicated. So we use 100 milligrams, then 200, then 400 milligrams with HMA, 600 milligrams with low-dose RSC. And then once we reach the plateau dose, then we add the posaconazole. When we add the posaconazole, we reduce the dose of venetoclax to 100 milligram, mainly because the tablets come in dose. If we could reduce it to 70 milligrams, we could, but it's not easily available to get that strength. If you use 100 milligrams of venetoclax plus posaconazole, it's important to realise that the conversion factor is about 8 to 10-fold. So really, you're actually giving about 800 milligrams of venetoclax in combination with posaconazole. And I mentioned to you before, if you use 28 days of that, you will have quite severe and prolonged cytopenia. So for that reason, if we are combining it with posaconazole, I reduce the duration of venetoclax to between 14 to 21 days. And then if the patient still has marrow suppression and prolonged count recovery, I shorten the duration until I find what the patient's individual tolerance is for the venetoclax with posaconazole.
Another question is, if the WBC count is low, can you straight away start venetoclax with 400 mg? No ramp up.
Yes, so we should divide patients into 3 different groups. So first of all is patients with bulk disease. So if the patient's got AML with more than 20% blasts, then regardless of the peripheral blood white count, I think we still need the dose ramp up because you can still get tumor lysis syndrome in that situation. If you have someone who's in remission, but you're using venetoclax for rising MRD, in the case that I illustrated before, then no dose ramp up is required because there's not many blasts present. In relapse disease, if people are using venetoclax, again, dose ramp up should be used. And I can't stress the importance of dose ramp up, even if patients have a low white cell count, because if you have someone with an IDH or an NPM1 mutation, even with a normal white cell count, we have also seen tumor lysis syndrome. So, for instance, a patient can have a potassium level of more than 7 within 4 hours if patients aren't adequately observed. And so I strongly advise not to do the dose ramp up and no biochemical observation in the outpatient setting, because you will have patients that have complications with that.
Another question is, how do you say that venetoclax-based therapy is not working? How many cycles will you continue to give before calling it a day?
Yes, so there was a paper presented at EHA recently on this topic, and it was illustrated that about 8% of responses are achieved with 2 cycles of therapy, which means that 20% of patients still can have a response with further cycles of therapy. The response rate cumulative approaches about 90% when you give 4 cycles of therapy. So obviously the gain in response rate beyond 4 cycles is relatively small. So our practice is usually to give 3 or 4 cycles of therapy. If there's no response, then we would switch to something else. The only other caveat I would say is that it helps to know if the patient's bone marrow blast count is coming down or not. If the patient's blast count is going up after 1 cycle or really hasn't changed at all, then I would be a little bit hesitant about giving further cycles of therapy.
Thank you. In a transplant-ineligible patient, will you continue venetoclax plus EZA indefinitely, or you can stop somewhere?
Yes, so that's another really good question, and currently we're just trying to put a manuscript together on this topic. And so there's 2 schools of thought here. One is you have a patient who's achieved a response, and you go indefinitely with the treatment combination, much like you would with azacitidine. The second possibility is you have someone that's had a remission for a good period of time, say 12 months, and if, say, MRD is negative, then you may consider ceasing the therapy. And so what we're trying to observe is if you continue therapy and the patient progresses versus if you give the patient a treatment holiday, what are the dynamics of relapse and what is the sensitivity to subsequent treatment and outcomes. And so at the moment, I don't have the complete answer as to what is the right thing to do. However, we are comparing cases amongst centres at the moment where patients have had a minimum of 12 months of therapy and comparing the practice of either continuation until progression or drug cessation and trying to identify what are the parameters that might indicate when it would be safe to cease therapy and that this does not lead to a detrimental outcome. So, good question. I don't have a definite answer yet, but maybe in about 3 or 4 months.
Another question is whether you see venetoclax moving upfront for the management of NPM positive AML without FLT3.
Yes, again, a really good question. And I think for older people with AML, I think, yes, that's what we would do. The question now is what about younger patients who are potentially fit for intensive chemotherapy? We don't have a definite answer for this, and I wouldn't recommend that people do this without randomised trial data at this stage. My recommendation is that if you have someone who's received intensive chemotherapy and with subsequent consolidation therapies, the NPM1 is not going down and remains positive, then perhaps switching at that point to a venetoclax-based regimen can be very effective. Also, for people that have completed intensive chemotherapy with a rising MRD, again, I would recommend venetoclax-based therapy over intensive salvage therapy, but with allogeneic transplant as the potential goal at this stage. For older people unfit for intensive chemotherapy, I think the answer is easy. Venetoclax plus either low-dose aracimab or HMA, in my view, is the new standard of care.
So there's another question related to, is there any place for HMA alone anymore?
If one wanted to be absolutely scientifically robust, you could argue that in some subgroups like P53 mutation, that technically there's not a clear survival benefit of the addition of venetoclax to HMA. However, what one needs to consider is that if you give the combination, even with p53 mutant AML, the response rate will be 55% still versus a much lower response rate with AZA alone. And I think we should use that response rate not as a means to an end, but a means towards getting some of these older patients who might be fit enough to a transplant. And I think that's where the benefit of having a response, even though it's not durable, is there compared to not having venetoclax on board. That said, there are subgroups of AML which do need novel therapies, and this p53 mutant subgroup is the major group where new therapies are required, and also patients with FLT3 mutant AML, because this is also a potent mechanism of ultimate treatment failure, even though you may have an initial response.
And this question related to TP53 mutated AML, what is the best regimen?
Yes, at the moment, the best regimen using available drugs is venetoclax plus HMA, and then going to a transplant if that is possible. For new agents, obviously people will be aware of many new agents moving into this space. Firstly, the anti-CD47 antibody, magrolimab, where response rates of 75% in combination with azacitidine have been observed for p53 mutant AML, and this may even spark a potential registration study in this space, which is currently being considered. The second drug of interest is APR-246, which is a drug which is thought to conform the mutant form of p53 to an activated form. Again, interesting response rates. The other two new drugs which I think are coming into this space might be HDAC inhibitors. So HDAC inhibitors in combination with venetoclax in preclinical studies is shown to have p53 independent activity. And the last combination is AZD2811, where there's been preliminary data presented that this aurora kinase inhibitor, again in combination with venetoclax, can have potential p53 independent activity. So at the moment, there are many new treatment possibilities being developed for this very tough disease area, but we don't have a definite at this stage.
Thank you. Your comments about oral azacitidine.
Yes, so I think oral azacitidine or CC486 was a real surprise because if you compare IV or subcut azacitidine with oral CC486, with CC486, the bioavailability is lower. Only 26% of the drug gets into the system. Second, the Cmax is lower compared to parenteral azacitidine. And third, even if you look at the methylation profile, only about 1/3 of genes are demethylated compared to injectable azacitidine. So the question is, how does CC486 work? The only thing we can surmise is that the extended duration of 14 days compared to previous studies which used either 5 or 7 days of azacitidine must be important somehow. Furthermore, CC486 can be delivered for much longer than you can IV or subcut azacitidine purely because of logistics. It's much easier to give a tablet for 2 years than parenteral azacitidine. So I think the formulation being oral does have substantial benefits, and beyond the maintenance setting, obviously there are many really enticing possibilities. So for instance, imagine CC486 in combination with venetoclax for frontline use in elderly AML. We now have the potential of delivering a completely oral remission induction combination. The possibilities for relapse refractory AML of CC486 plus FLT3 inhibitors, IDH inhibitors, or even triplets with venetoclax and CC486. So I think CC486 could become a new backbone for a whole series of new novel combinations which would replace parenteral azacitidine.
Do you believe in 10 days of decitabine therapy?
So the 10-day decitabine therapy was popularised in the NEJM paper, which showed activity in patients with P53 mutant AML. However, there has been a randomised study presented by Nicholas Short from MD Anderson, where he compared 5 versus 10 days of decitabine, and unfortunately there was no improvement in overall survival in P53 mutant patients. So I think at this stage, although the response rates are interesting, my guess is that patients would progress with biallelic P53 mutations. And so overcoming biallelic P53 mutations is now the major unmet need in the AML field, how to do this. And I think we need new agents for this area, or allogeneic transplant if the patients are fit and eligible enough.
Is there any place of auto transplant in AML?
Yes, it's a very good question. It's not a practice which we use a lot in Australia. I know the Hobon group are very supportive of hematopoietic stem cell transplant, particularly for intermediate risk patients, potentially with MRD by flow cytometry. At this stage, I think with maintenance therapies potentially becoming available, venetoclax being available, targeted therapies becoming available, I think the role of autografting personally will become less and less, and I think we need to understand more the individual patient and a more tailored approach with or without conventional allogeneic transplant to try and get the optimal outcome for our patients. And with donor availability now becoming almost universal with haplo and cord transplants, I'm not sure if there's a strong role for autografting anymore.
This is again regarding posaconazole and posaconazole. Can voriconazole be a replacement for posaconazole with venetoclax?
Yes, so although the pharmacokinetic studies were generally done with posaconazole, there are some situations where we do use voriconazole because the patient, for various reasons, can't tolerate posaconazole. I think it's appropriate to use with the same dose adjustments that we use for posaconazole, but I just make the proviso that the published pharmacokinetic data is more, more widely available for posa versus vori, but theoretically it is possible.
Does the dose of venetoclax changed with antiemetics?
No, we use the same dose with antiemetics. The only other situation where we adjust the dose of venetoclax is in combination with quinolones. So if you use ciprofloxacin, for instance, then you need to reduce the dose of venetoclax by 50% rather than by 8 to 10-fold. And the other most important thing, because it costs you absolutely nothing, is that you must combine venetoclax with food. If you don't get the patient to take venetoclax after a meal, then you may be giving less than 50% of the dose. And so that's a complete waste of time if we don't do that.
Does venetoclax cause bleeding in GI tract without thrombocytopenia?
Not that I'm aware of. So with the precursor molecule ABT737, this did cause thrombocytopenia, and obviously there's a bleeding risk. We must be very careful when we combine venetoclax with intensive chemotherapy, however. We have a paper which should be in JCO soon, which is combined 5+2 induction with venetoclax. However, when venetoclax is combined with intensive chemotherapy, there have been some problems, including GI tract diarrhea. And we're not sure exactly what the mechanism is. However, it should be considered that venetoclax is a moderate PGP inhibitor. And so, for instance, if you combine venetoclax with a PGP substrate, such as mitoxantrone, with Aracid, for instance, then the mitoxantrone concentration may be increased in the gastrointestinal tract because PGP pumps are present on gut lining cells. And so if you increase the chemotherapy dose in that, you may cause an increased risk of colitis, which I think has been reported by some colleagues. So we have to be careful about these potential drug-drug interactions and follow the published literature if possible at this stage.
The question is, what is the best technology to monitor MRD in practice?
Yeah, so although flow cytometry is the most widely available tool, certainly the sensitivity and the reproducibility and the standardization of RT-qPCR is certainly, I think, the best option at this stage. And so the only validated options with respect to RT-qPCR, obviously core binding factor AML, promyelocytic leukemia, and NPM1 mutant AML. MLL fusion are also possible with RT-qPCR, and again, you can get very good sensitivity. The benefit of RT-qPCR is that these assays are usually can be done in triplicate, and so very tight reproducibility can be demonstrated. Second, the amplification of genes gives RT-qPCR an advantage over just doing analysis of genomic DNA. And third, with RT-qPCR, you usually have a control housekeeping gene, and so this gives you a better idea of quality of the sample, which you do not get if you just use NGS methods alone. So I think where RT-qPCR targets are available, that is the method of choice. Digital PCR is also useful, however, not so much validated for other targets like IDH1 and 2. There's also NGS-based methods, but obviously sensitivity and reproducibility is more complicated. And then last of all is flow cytometry for patients where we do not have a trackable marker.
Questions about secondary AML after MPN, which will be the best novel agent?
Yeah, so this is a very challenging area because NPM1 secondary AMLs were excluded from both VIALE-A and VIALE-C. And the only study that I'm aware that has some of these patients that have potentially an interesting outcome is in fact this study that was done with Glasdegib. And so if you look at the Glasdegib paper and you look at the forest plot, you will see that secondary AML in fact did the best amongst those patients. Whether that's something that will be borne out in bigger studies, I don't know, but we need better therapies for transformed MPN. If we have MPN transformations, I think we need to look at the genetic biology of that. So for instance, you can imagine there'll be transformations from CML background, CMML background, and also JAK2 positive graft backgrounds. And I think there are possibilities for all three subgroups. So for BCR-ABL, the possibility of using a TKI against BCR-ABL in combination with a pro-survival inhibitor, I think is a really interesting possibility for the future. For patients with JAK2 mutant AML and myelofibrosis, there's very interesting data with ABT737, which also targets BCLX in combination with a JAK2 inhibitor. And for other MPNs, potentially mastocytosis with KIT, again, looking at the target biology and combining with a pro-survival inhibitor, either BCL2 or BCLX, with or without chemotherapy, I think will be key explorations for the future.
Thank you. What is the best timing of doing the first MRD analysis?
Yeah, so again, it depends on what you're trying to do. So as I showed you before, there are two key objectives with MRD. First is to identify patients that have had a suboptimal response. And second is to identify early progression. And so obviously those two objectives determine when you should do your testing. With respect to suboptimal response, my feeling is that after one cycle is a bit early because we often see many patients that have progressive declines in MRD, second or third cycle of chemotherapy. And so making interpretation too early has risks of false positives. If you do it at the end of consolidation, then obviously you're not going to give any more therapy, and so a cut point at that may be a little bit more useful. However, there's always going to be a 25% false negative and false positive rate. With respect to MRD progression, what we generally find is if the patient has negative MRD and then it becomes positive, or if it's a low positive and becomes more strongly positive with a log increase, clinical relapse is almost universal. And so in that situation, the predictive probability is much higher. And so I see rising MRD in the future as being a new frontier of salvage therapy, rather than waiting for the patients to have morphologic relapse, but treating at 2 or 3 months prior to that with targeted or novel therapies, I think will be really interesting research possibilities for the future.
Is MRD used for approval of drugs by FDA?
Now developing trials specifically for MRD, either MRD persistence or MRD progression. We have the very good example now of blinatumomab in ALL, which is approved for MRD positive patients. And I think this type of lead will eventually move into the AML field. What we really need, however, is good reproducible markers which can be quality controlled, and also very clear definitions of what it means to be MRD positive or MRD failure. And I think the ELN have done a good job in giving us some guidance in that area. So I think it's a matter of time.
Why is FLT3 mutation irrelevant in acute promyelocytic leukemia?
Irrelevant because previously when we used ATRA plus chemotherapy, as many of us will know, there was about a 25 to 30% relapse rate in patients that had FLT3 ITD also present. However, with the combination of ATRA plus arsenic, the adverse prognostic factor of FLT3 seems to have been erased. And so therefore, for APL patients, regardless of FLT3 mutant status, if you use ATRA plus arsenic plus idarubicin or other chemotherapy for high-risk disease, outcomes now are so good that FLT3 mutation has lost its prognostic relevance.
Are there FLT3 mutations which are neither IBD nor TKD?
Yes, there are. And so we have found when you use an NGS-based method, you can now find many new variants of FLT3 mutation, which are not just insertions and not just tyrosine kinase domain mutations. We have, for instance, found a C-terminal truncation variant, and that C-terminal truncation variant was cloned into a cell and shown to have, again, inner function properties. So there's many cryptic possibilities. However, most of the time we wouldn't pick that up because most of us use capillary electrophoresis as the screening tool, and that will mainly just pick up the insertions and the TKD.
Will you use midostaurin in this situation? Difficult to pick it up.
Oh, you mean in FLT3 variants?
Yes.
Yes. I think there's no data for that. And as some people will know, there was, in fact, one mutation variant which was actually associated with midostaurin resistance. And so I think these novel variants will remain cryptic until we can do some function mutation correlations, which may have to be done ex vivo in order to understand what these variants mean.
When do you use CPX351?
Yeah, CPX351, we don't use a lot of that in Australia at the moment. However, obviously its strongest data is in patients between the ages of 60 and 75 with secondary or therapy-related AML. The interesting thing is whether patients who are in that older age group would do better with CPX351 or Ven-Aza, because if you look at the actual response rates, the response rates are actually higher with Venasa than they were with CPX351. However, CPX351's major benefit was in patients that went to allograft, and as people will know from the paper by Jeffrey Lancet, in fact, most of the survival benefit of CPX351 were in patients that went to allograft, and they had a better outcome than in patients that did not go to allograft. And so it's possible that CPX351 just delivers more patients to transplant, and the survival benefit is due to the allograft. And so if you get the patients to transplant with another method, like Venasa, for instance, you may get a similar outcome. That said, I've been told by colleagues that CPX351 is very well tolerated, and patients, I've been told, don't even lose their hair. So there may be some tolerability benefits of CPX351, which could perhaps substitute from conventional chemotherapy. But beyond secondary and therapy-related AML, we don't have proper randomized data to prove efficacy. There are patients that are currently being tested in trials using CPX351 plus venetoclax, and those types of studies will be interesting when they read out.
Thank you. When do you use gemtuzumab?
Yeah, so gemtuzumab zocamycin is again another interesting drug. The strongest data is in core binding factor AML, and the question in core binding factor AML is how many doses to use. So people are aware that the French Alpha 0701 data use a day 1, 3, and 5 schedule, whereas the UK just uses a dose on day 1. And at the moment, there's no randomized data to say whether 3 is better than 1. However, at the EHA meeting, Nigel Russell from the UK group presented data that 2 doses of GO were not better than 1 dose. And so at this stage, many of us who are using GO for the first time in CVF, I guess putting a toe in the water and just using GO on day 1 and hoping that that will produce a benefit because that's where the data is versus the 3 doses. The reason for using it in CVF is because these patients are less likely to go to allogeneic transplant. And so if you can keep GO beyond 3 months from transplant, then the risk of VOD is less. And so that's the reason why it's used in CVF. However, the primary data was in de novo AML by the French group in patients between the ages of 50 and 70, and there was obviously a reasonable survival benefit shown there. So there's also other groups beyond CVF, but it depends on how available and how costly it is to use that drug in your country.
One last question. If allelic ratio is based on the number of the blasts, then will you trust it if the marrow sample is dilute?
Yeah, so although the ELN has proposed some value to allelic ratios, particularly around the 0.5 level, I'm very strongly putting forward the proposal that we should never just treat patients on a single number. And the reason for that is it's known that the FLT3 allelic ratio is dependent on sample quality, as you've suggested. Second, people may or may not know this, but even if you do a different number of PCR cycles, you'll get a different result. And so the original method by Kathleen Murphy was with a 35-cycle PCR. However, with the ratified trial, this was done with 27 cycles. If you do fewer cycles of PCR, you will get a relatively higher ITD ratio because the more cycles you use, the more you will amplify the shorter fragment, which is the wild type. And so it's important to look at the number of cycles within your lab, and if you want to reproduce the ratified data, you should ask them to move to a 27-cycle method rather than 35. But I would always look at other things like co-mutations, DNMT3A, second NPM1, and if you've got NPM1, then track MRD, and I would also look at flow MRD if you've got that available as well. So I would never use the ratio on its own to make a decision. And my general policy is that I'm looking for a reason to not take the patient to transplant at the moment, because I think the default position still with FLT3 mutant AML is that you should take the patient to transplant, and this is a very good reason not to, either MRD negative, poor patient, poor poor donor, etc. But don't use 0.5 as a reason to not do it.
One or two more questions I've just got in. Will you give azacitidine and lenalidomide combination?
Yes, it's a good question, because I did a trial with azacitidine and lenalidomide many years ago in frontline elderly, and we also used azacitidine plus lenalidomide in maintenance therapy as well. In terms of subgroups, there is an interesting paper produced where lenalidomide plus azacitidine has, I think, 4 out of 4 remissions in patients with inversion 3 or translocation 3 AML, which is the worst cytogenetic risk group that we know.
Hello?
The rationale for this is not entirely clear. The other potential benefit of lenalidomide is in combination with azacitidine in the post-allograft relapse setting. There was a nice paper from a German group several years ago that suggested that patients relapsed AML after allograft failure, that there was a response rate, I think, above 50% with azacitidine plus mini-dose lenalidomide. So that is either 5 or 10 milligrams for 21 days. And so in this difficult situation of post-allograft relapse, we're currently thinking about using azacitidine plus lenalidomide, alternating with azacitidine plus venetoclax, using azaven to debulk the patient, and then azaven plus DLI as an immunogenic approach as an alternating sequence. This is completely untested and unpublished, but this is just my thinking at the moment as to how to treat a very difficult patient population, in the absence of a targeted therapy, of course.
Now really the last question. Why is midostaurin started from day 8 and why not from day 1?
Yeah, so when Richard Stone did his original phase 1b study, he did in fact test the 2 schedules, and he found that the direct combination with chemotherapy was more toxic, and so that's why he went to the sequential schedule. Furthermore, work done by Mark Levis's group suggests that if you combine the TKI directly with chemotherapy, the TKI might cause cell cycle arrest, and this may hinder the activity of cell cycle dependent drugs like conventional.
हाँ पहले पेट करा लेते हैं, उसके बाद फिर वो TURBT के लिए भेज देंगे। TURBT में अगर लो ग्रेड है तो ठीक है, बट अगर हाई ग्रेड हो गया या फिर केस बड़ा है तो 2 स्टेप में सर्जरी होगा। पहले एक बार TURBT करेंगे, सेकंड टाइम पूरा ब्लैडर निकालने के लिए बोलेंगे, ठीक है। तो उस टाइम एक बार वो TURBT करने के बाद तो रिपोर्ट बता देना, ठीक है। हाँ पेट के लिए एडवाइस नहीं किया था, एडमिट कर दो वो ठीक है, लेकिन नहीं अगर कैंसर है, अगर मान लो कि कैंसर फैल गया है तो फिर TURBT करने का कोई मतलब नहीं बनता है ना, इसीलिए बोल रहा हूँ। तो TURBT मतलब पेट करने में पता लग जाएगा कैंसर उसी पे है कि नहीं, तो इसीलिए एक बार तो कराना है ही। और ऐसे जगह पे दिखाने के लिए बोलो जहाँ पर सारे टीम एक जगह पे है, मतलब यूरोलॉजी भी है, मेडिकल ऑन्कोलॉजी भी है, सर्जिकल ऑन्कोलॉजी भी है, इस टाइप की जगह पे नहीं। आप मतलब ऐसा नहीं कि धर्मशिला में दिखाना है उनको, ये फोर्टिस है, मेदांता है, फिर इस टाइप की जगह पे दिखाने के लिए बोल दीजिए, अच्छी जगह पे जहाँ पर पूरा नहीं, मतलब जैसे राजीव गांधी है, बहुत अच्छा सेंटर है, ये सारी जगह पे दिखाने के लिए बोल दीजिए। वो कहाँ पर दिखा रहा है तो मैक्स में उन्होंने मेडिकल ऑन्कोलॉजी का ओपिनियन नहीं लिया उस टाइम। अच्छा, तो उनको उसी में ही बोल दो कि ठीक है सर, हम उधर से एक बार उसी हॉस्पिटल में मेडिकल ऑन्कोलॉजी की इसको दिखा देंगे, वो सजेस्ट कर देंगे क्या क्या है ना, क्योंकि इसमें तो दो तीन दोनों दोनों का ही चाहिए ना, यूरोलॉजी वाला भी चाहिए, मेडिकल ऑन्कोलॉजी वाला भी चाहिए। और इवन अगर, हाँ, और इवन अगर वो ब्लड से ट्यूमर निकालते हैं उसमें रेडिएशन का वाला भी चाहिए, तीनों चाहिए, ठीक है। तो तीनों से कंसल्ट कर लेंगे पहले ऑपरेशन से पहले, एक दिन में तीन का कंसल्टेशन हो जाएगा, उसके बाद तीनों मतलब जिसमें लोग ज्यादा बोलेंगे उसके हिसाब से उनको जाना है। यूरोलॉजिस्ट वाला तो पहले ही बोलेंगे कि ठीक है सर्जरी करके देखते, सर्जरी तो करना ही है, लेकिन अगर उस एक ही स्टेप में अगर सर्जरी कर सकते हैं तो सबसे अच्छा है, क्योंकि दो बार का खर्चा नहीं लगेगा ना। हाँ हाँ, पेट तो करना चाहिए एक बार।